Good morning, everyone. So first of all, I would like to thank Manoj sir for this opportunity, and I would like to congratulate him for organizing this type of CME in third space endoscopy. So the topic given to me is spaced out in endoscopy opening the doors. So basically, I have been asked to talk about introduction to third space endoscopy, the various procedures that are described in third space endoscopy, the adverse events associated with third space endoscopy, and the training and the learning curve associated with these procedures. So as we know, three spaces have been described in GI practice. The first space is the luminal space. The second space is the peritoneum, and the third space that recently has been described is the submucosa. So submucosal space is the space between the mucosa and the muscular layer, and where a lot of procedures can be done, including the prototype procedure, which we all know is POEM. So a little bit about the history. The term third space endoscopy was coined by Kashyap and Pastricha in 2013, also called submucosal endoscopy using a mucosal flap valve. Sumiema et al. Reported the first submucosal tunneling for access to the peritoneal cavity, and Pastricha et al. Performed endoscopic submucosal tunneling and myotomy in porcine models, and the first POEM in humans was reported by Inu et al. In 2010. So these are the various procedures which can be done in third space endoscopy. Achalasia for achalasia cardia POEM, for G POEM for refractory gastroparesis, then Zenker's or Z POEM for Zenker diverticulum, parrectal endoscopic myotomy for Hirschsprung disease, diverticular POEM or D POEM for esophageal diverticulum, then submucosal tunneling endoscopic resection for submucosal tumor or various subepithelial tumors, and paroral endoscopic tunneling for restoration of the esophagus that has been described in esophageal stricture. Now, this is the schematic diagram of third space endoscopy. As you can see, the incision is made proximal to the desired lesion, which has to be cut or taken out, or where myotomy has to be done. Then the tunneling is made in the submucosa. Here we should be a little bit careful, so that sometimes as an adverse event, tunneling has been described in the muscularis mucosa also, in lamina propria also. So here the tunneling should be done in the submucosa after adequate injection, and after dissection in the submucosa, the desired plan of action, if it is a myotomy for POEM or if it is a resection of tumor from the muscular layer, is done. Then the defect is closed with clips, and this area, this mucosa, this acts as a mucosal flap valve so as to close the perforation which we have created. So the various instruments that are required for this type of procedures are high definition endoscope, which should be equipped with the water jet and flushing pump, distal transparent cap, then carbon dioxide insufflator with very low flow tubes, electrosurgical generator, injectors, injected solutions, electrosurgical knives, hemostatic forceps, clips for closure, and all third space endoscopic procedures are performed under general anesthesia with endotracheal intubation. Now, this is the procedure POEM, which is the prototype of all third space endoscopy procedures. So usually a submucosal bleb is created, the proximal to the lower esophageal sphincter. Now, various lengths of myotomy have been described depending on the type of the achalasia. So after the incision, dissection is done in the submucosal space. Then there are ways to know whether we have reached the cross the G junction or not. Here you can see blanching of the mucosa in the G junction, and then myotomy is done. After the myotomy, the defect is closed with the hemoclips. Now, there are various studies which have described the results of POEM, and here some large studies have been described in this table, of which Inu et al. Has described more than 500 patients, in which the follow-up period was up to 36 months, and these procedures was highly effective in as evidenced by the decrease of Eckhart score from 6 to 1, and the success rate was around 91% at 1 year and 88% at 3 years, and the reflux was around 16.8% at 2 months, and total adverse events was around 3.2%. And there are various other large-scale studies also which have described POEM, like by Zahir Nabi et al., who they have described about 400 patients in whom there are similar conclusions. The treatment success was 94% at 1 year and 91% at 2 years, with a complication rate of 4.5%. So for the next procedure, third stage procedure is GPM, which is usually done for gastroparesis. So here also, now which patients to select for GPM has been described. The patient selection criteria depends on gastric scintigraphy, and also there is a scoring of symptoms, which is known as GCSI, that is the gastric cardinal symptom index, by which you can stratify patients, like select patients for the procedure. And also recently electrogastrography has come, which has also helped in detecting gastroparesis. Usually the causes are, it can be idiopathic gastroparesis, or it can be diabetic gastroparesis, or it can be post-surgical gastroparesis. So here the mucosal bleb is created at around 5 centimeter proximal to the pylorus, and the submucosal tunneling is done. Then the circular muscle, that the pyloric muscle is identified, the myotomy, full thickness myotomy is done, and then the defect is closed with the hemoplex. So the clinical outcomes of